Yeah, good afternoon, everyone. Two important and the basic problems one tend to place with the phacoemulsification. Today I'll be talking to you regarding capsular contracture and capsular distension syndrome. The main purpose of surgery, as we know, is achieving a perfect lens centration, preventing the IOL tilt and the distortions, and obviously the getting a pristine optical quality for the better outcome. The anterior capsular contracture and shrinkage usually occurs much earlier than the posterior capsular opacification, usually within the first 3 to 6 months. The contracture involves the anterior cuboidal lens epithelial cells, which in turn leads to metaplasia and myofibroblastic transformation, which causes the contracture of this capsule. So when to suspect a capsular contracture is, on direct visualization of the slit lamp, obviously one will be able to make out the capsular contracture. If there is a change in the IOL position in the post-operative period, you should suspect capsular contracture. And obviously, resultant shift in refraction. So that gives a clue that patient must be having a capsular contracture. Why we should look into this is, one, it obscures the vision, changes the IOL position as well as the function. And of course, if the contracture continues, it can lead to the zonular discence, and the IOL capsular back complex can get dislocated sometimes. In the era of presbyopic correcting IOLs, it carries much more relevance because the progressive contracture leads to the decentration, which reduces the optical quality as well as the best corrected visual acuity. So one need to look at which are all the high risk patients and how to avoid these complications. One should closely look into this. So what are the predisposing factors for the optical capsular contracture? One, obviously, as we know, pseudoexfoliation, uveitis, retinal degenerations like retinitis pigmentosa, eye myopia, myotonic dystrophy, trauma. Suppose somebody who has undergone a previous trabeculectomy or vitrectomy obviously will have a compromised zonules, which also contributes for the capsular contraction, diabetes, and the instability of the blood aqueous barrier. Does the creating of a large capsular excess prevents the capsular contracture? Obviously, it is a good sign if you do a good capsular excess, but it doesn't prevent the minimal capsular contraction in spite of a good optimal large rhexis. But only advantage is it gives a large unobstructed visual area if you got a good rhexis. So don't leave the patient with a small rhexis. Try to do an ideal rhexis. Removing of anterior lens epithelial cells, definitely yes. The very maneuvers, very modified maneuvers, you can do it. You can polish the anterocapsular remnants of the anterior capsule, or you can rotate the nucleus multiple times when you do an hydrodissection. But there are some papers which show that if you get rid of anterior epithelial cells, even though it reduces the capsular contractions, sometimes it may induce early PCO also. So it's on the contrary to that, you should compromise one of them. So IOL design, obviously the silicon plated IOLs tends to have a more capsular contracture compared to the acrylic. Even the silicon optic. The Prolene haptics tends to have a much more capsular contracture. The study reveals that whether the 3-piece or a single piece acrylic has more contracture is variable results which has shown. The square edged obviously prevents the PCO rather than the anterocapsular opacification. So carefully consider these factors, especially when you're considering a presbyopic correcting IOLs. Capsular tension rings to an extent prevents the capsular contracture and prevents the decentration of the IOL. In fact, the studies have shown that in a high-risk patient, just placing a CTR is not enough. Sometimes you have to do a suture the capsular tension rings as well as the segments to prevent the late onset capsular contracture and or subluxation of these IOLs. So try to suture these additional things like segments and the CTRs in high-risk patients. So here is a patient with due to the anterocapsular contracture, you can see a markedly thickened anterior capsule. There will be a posterior vault which causes the increase in AC chamber depth. Simple treatment like Nd:YAG laser to the anterior capsule sometimes can bring about the relaxation of the capsule. You have to use from the capsular marginal edge, you can apply the Nd:YAG lasers for 0.5 to 1 mm of the optic IOL optic. From that, you should give a relaxing incisions, which relaxes the capsular contracture and brings about the relief from this contracture. So there will be whatever the only thing is incisions over the IOL optics should be avoided, haptic should be avoided because sometimes it can cause an asymmetrical lens tilt. So here the video showing how to give a relaxing incision on the anterior lens capsule. Okay, post Jaeger, you can see that this is left side is a pre-laser picture, and on the right side is a post-laser treatment. There is a reduction in the antechamber depth because of the relaxing incision, the lens has moved back to its position. So whatever the residual refractive error you had, it has been. Another thing is a surgical maneuver, you can do it. The bimanual things are better, especially if there is a severe contracture, because the longer the disease process, there will be a lot of adhesions. If you do it unimanually, you tend to try to peel it. You may compromise the zonules, or you may cause further complications. So you need to cut, use a scissors or a cutter, make a relaxing incisions, do a bimanual maneuver, take pupillary margin as a reference mark, go around it and cut as much as possible to enlarge the capsular opening. So you have to choose the technique which suits you the better. Either you can use the cutter, or if there is a dense membrane, probably one requires a scissor. Once you do that, you will get a good opening in the anterior capsule. Sometimes you can use a femto laser to relax this anterior capsule. This is a capsular contracture. The femto laser is being applied to relax the capsular phimosis. This is the incision which is being applied. So if you got an access to the femto laser, definitely femto laser anterior capsulotomy is also an option. So what are the preparations and actions one should do in capsular contraction syndrome is, be aware of the iris conditions, select the appropriate IOLs, consider CTR and segments, preferable to suture them, and you can polish the anterior lens capsule also. Multimodal approach, sometimes you may get away with Nd:YAG laser, sometimes you have to do a surgical maneuver to come out of these complications. The second complication is a capsular distension syndrome. Basically it is nothing but a turbid fluid which occurs between the IOL and the posterior capsule. There are three classifications which have been done. The classification either could be intraoperative capsular bag distension syndrome, early onset or a late onset. Depending upon the material which accumulates, either it could be fibrotic type of material which is there, inflammatory or non-cellular. Fibrotic usually occurs because of the lens epithelial cell proliferation, and the treatment for this is disruption of the capsular bag. Inflammatory typically tends to occur in the early period because of the anterior chamber cellular reaction which occurs and causes the turbid fluid between the lens and the posterior capsule. The anti-inflammatory drugs helps in these cases. Non-cellular, of course, if you leave behind a lot of viscoelastics behind the IOL, tend to cause this capsular distension syndrome. I told the causes for each one of these things, early onset and late onset. The another classification is looking at the transparency of the PC and transparency of the anterior capsule, as well as the turbidity of the fluid, whether it's a transparent fluid or a turbid fluid. Based on that also, severity you can classify it as type 1, type 2, type 3 and type 4. So what are the differential diagnosis for capsular bag distension syndrome? Sometimes you may confuse this with the severe uveitis. Even sometimes if you don't do a proper examination in undilated pupil, you can think of an PCO also, chronic ENDOF, then the pupillary block glaucoma, and sometimes nowadays with the recent opaque hydrophilic IOLs, you may say that this is an opaque hydrophilic IOL rather than looking at the proper examination. Antersegment OCT definitely gives a clear-cut the clue to the diagnosis. You can make out the clear separation, the fluid accumulation and the level of the PC as well as the IOL. So one should do ASOCT or in UBM to get to this. So one thing is early asymptomatic patients you can observe. If there is a cellular deposits, you can do an anti-inflammatory drops. Nd:YAG capsulotomy definitely helps, but one thing with Nd:YAG capsulotomy in capsular distension syndrome is sometimes it can induce an inflammation. Whatever the fluid there in the bag can go into the vitreous cavity and can induce an inflammation. Sometimes the slit lamp needling itself can enough to bring about the fluid and the other things. Anterior chamber aspiration and the capsulectomy also you can do it with the pars plana route. But the disadvantage with pars plana vitrectomy and posterior capsulectomy is more invasive procedure. But the only thing is you can get rid of the fluid completely so that the vitreous inflammation and the contents going into the vitreous cavity will be reduced. This is the pre-op and the post-treatment pictures. You can see the turbid fluid in the upper picture, which has been a post-treatment, post-YAG laser, it is completely resolved. The another thing you can do is, if you don't want to do, if it is a transparent PC, you don't want to make an opening in the PC, you can do a small peripheral iridotomy which ruptures the anterior capsule. So whatever the fluid accumulated, which comes into the anterior chamber and then gets absorbed, or you can do an AC wash just that to get rid of these things. So Nd:YAG laser, it is nothing routine from the regular YAG capsulotomy what we tend to do. So once you do that, you tend to get rid of the fluid and the fluid goes into disappears and you will get a clear visual axis. Sometimes just separation of the capsular adhesion to the lens optic itself is enough to tap this fluid. So go inside, just separate the capsular rim, so you will get access to the turbid fluid in the posterior, behind the lens. Just separate that capsular adhesion was there to the lens. Once you're done, just tap the IOL, all the fluid comes out, whatever the retro IOL accumulated fluid is there, comes onto the anterior chamber, and you can just wash it to get a clear visual access. This is my last slide, I'll be finishing it, KP. You can see that all the turbid fluid has gone away, and that now it looks a perfect thing. Okay, thank you. These are the two common complications you tend to see, and you can manage it case to case basis and get a good outcome of this. Thank you.
Yeah, one clinical point I would like to ask you, Sunil. I think most of us here are cataract surgeon. So once you implant the intraocular lens, you tend to see within the bag, you tend to see a stretch mark in the PC, the straight stretch mark. Sometimes this stretch mark really irritates the patient very much, and they come with a lot of glare and halos. So when you'd like to do YAG, do you want to do very next day YAG, or do you will wait?
Not definitely in the IOL post-operative, for immediate post-operative period. So preferably you should allow some fibrosis to occur, then better to do an YAG laser than an immediate post-operative period.
And one more take-home message for beginners, those who do cataract surgery. After you finish your phaco, after you polish the PC also with the regular, whatever the cleaning method, whether bimanual or whether it is coaxial or even Simcoe, the best method to prevent PCO, what I observed, take a 20 gauge bend cannula with a 2 cc syringe. Slowly you flush within the bag, just minimum flush. So whatever the epithelial cells which is sticking onto the PC, that will come out, and the incidence of PCOS drastically coming down.
The one more thing I would like to add is whatever I showed of the capsular contracture and is all related to the adult cataracts. The pediatric capsular contracture, it's a different ball game itself. You will not be able to get away so easily. There will be severe contracture. Probably you may end up with IOL exchange sometimes, because the fibrosis and adhesions causes, if you try to pull it, do a surgical maneuvers, you may induce retinal damage or zonular dialysis and all. So pediatrics patients, you should be much more careful than the adult patients. Thank you.